Hi everyone, welcome to the Academy of Online Radiology Education. My name is Sabrina Hsiao and I'm a fourth year medical student at the George Washington School of Medicine in Washington, D.C. Today we'll be exploring PSMA PET and prostate cancer and its clinical impact on staging and treatment. Thank you to the ACORE editors and specifically Dr. Lena Carute and Dr. Marlon Stewart for helping me edit this presentation. In order to introduce our topic for today, we will explore firstly how prostate cancer is one of the most common cancers in men, and staging directly determines whether a patient receives local curative treatment or systemic therapy. Conventional imaging with CT and bone scan has been the standard for decades. However, it does have its limitations, particularly for nodal disease and early skeletal metastases. This has driven the development of PSMA PET-CT, which is now changing how we stage and manage prostate cancer. Specifically, PSMA refers to prostate-specific membrane antigen. In regards to background and clinical context, traditional staging uses abdominal pelvic CT for node evaluation, as well as TC99M bone scan for skeletal metastases and MP-MRI for local staging. There is a problem that exists in which the pro-PSMA trial addressed, which is that CT and bone scan had a combined accuracy of only 65%. Namely, CT misses micrometastatic nodes because it often relies on size criteria alone, and bone scan is prone to false positives from degenerative changes and false negatives in early lytic disease. As a result, this can lead to understaging and overstaging. That clinical context helps us better understand our relevant studies that we will be exploring today. So firstly, as mentioned, the PRO-PSMA trial was the first prospective randomized study comparing GA68 PSMA PET-CT to conventional imaging in high-risk prostate cancer. PSMA PET achieved 92% accuracy versus 65% with sensitivity of 85% versus 38% and a specificity of 98% versus 91%. Taking that together, management changed in about 29% of patients, with findings dropped from 23% to 7%, and radiation exposure was lower. Overall, an analysis of this suggested that PSMA PET-CT may be cost-effective and more accurate. The next study we will explore is in regards to the clinical applications of PSMA PET from the Journal of Nuclear Medicine in 2021, which was a review of the indications across the prostate cancer spectrum. In primary staging, it is superior for nodal and distant metastases with management changes in about 28% of cases. In biochemical recurrence, positivity rates range from 33 to 50% at PSA 0.2 to 0.5 to over 90% at PSA above 2.0. PSMA PET also serves as the companion diagnostic for Lu-177 PSMA 617 radioligand therapy, which delivers targeted radiation to PSMA-expressing cancer cells. We will be taking all these clinical findings from the studies and discussing them later, so please keep these in the back of your mind. Thirdly, we will be talking about a systematic review / meta-analysis that looked at the F18 tracer PSMA 1007, which has a longer half-life, which enables centralized production and wider distribution. Specificity ran high, but sensitivity was moderate compared to GA68. The key pitfall is increased nonspecific bone uptake, which can mimic metastases and lead to false positives. The last study we will be exploring was focused on guidelines made by various groups. So this was a joint guideline effort in order to standardize PSMA PET selection, acquisition, interpretation, and reporting of PSMA use and integration in the clinical workspace. These guidelines endorse PSMA PET for staging unfavorable, intermediate to high-risk disease and biochemical recurrence. Nodal specificity is 95% or greater, but sensitivity is roughly about 40%. So a negative scan cannot exclude micrometastatic disease. The guidelines were significant because they recommended standardized reporting use among PSMA RADs and PROMIS V2. So kind of taking all these findings together, in practice, PSMA PET-CT is now increasingly first line for staging. It changes management about 1 to 4 patients and is essential for selecting Lu-177 PSMA 617 candidates. There are some caveats that need to be addressed in that imaging should be done before androgen deprivation therapy initiation. A negative scan ultimately doesn't rule out micrometastatic disease, and improved staging accuracy has not yet been proven to improve survival, which leaves space for further implications within the field of prostate management. We will be discussing the main takeaways from the studies that we discussed. So firstly, we talked about study 1, which was the pro-PSMA trial, and this showed that PSMA PET-CT has been shown to improve staging accuracy in high-risk prostate cancer, roughly about 92% versus 65%. And this was really the first prospective randomized study comparing GA68, PSMA11 PET-CT to conventional CT and bone scan alone. We next discussed study 2, which looked into the changes in management in approximately 1 in 4 patients. This study looked at reported management changes in about 28% of cases in the primary staging setting, and the pro-PSMA trial similarly found changes in 29% of patients. So across the studies, we can see that roughly about 1 in 4 patients had their treatment plan altered based off the PSMA PET findings. Next, we talked about study 3, and this meta-analysis highlighted that F18 PSMA 1007 has a longer half-life, under 110 minutes, compared to 68 minutes in GA68. And this allows for centralized production and a wider regional distribution to sites without an on-site cyclotron or generator. So overall, we can see that F18 PSMA tracers may improve access. We next talked about ultimately how a negative PSMA PET does not rule out micrometastatic nodal disease. And we further discussed this in the context of the EANMSNMMI procedure guideline 2.0 by Fendler and his fellow colleagues, which reported nodal detection specificity of 95% or greater, but sensitivity of only about 40%. So this means that small volume nodal metastases cannot be only missed, but also that we should keep in mind that a negative CT scan should not provide false reassurance. And then lastly, something that we can take away here is that standardized reporting surely improves consistency. And we saw that within the guidelines that we discussed, and overall kind of the frameworks in these different ways that the PSMA PET clinical applications were showing in these studies. It's important that there's clear communication and integration among radiologists, nuclear medicine physicians, and ultimately other physicians in the context of patient care and fellow other physicians. So for our final conclusion, we can see that there are changes to the standard of care that can be considered when it comes to improving prostate cancer staging and influencing treatment decisions. As mentioned, it's important to gain familiarity with its strengths, limitations, and reporting frameworks within radiology education and workspaces. And looking ahead from all of these discussions and findings from the trials, we can think about how prospective outcome studies are still needed to understand if staging translates to survival benefit, and ultimately growing availability of the tracers mentioned may improve access through centralized production and distribution. Thank you so much for joining us at the Academy of Online Radiology Education.